Okay, good evening, everyone. I think the doors closing is a good signal for us to start. So, welcome. Really wonderful to see you all here for, to start with, our annual general meeting. And then we have really a special celebration that will follow our AGM as well tonight. So, it's my pleasure to welcome you all to the annual general meeting of Cancer Trials Australia, which is conducted to review the year's activities of 2022 and separately celebrate a milestone of 30 years since our genesis. And we have some of our founding members here, which makes this a very special evening. So we'll complete the formal AGM first before moving into the less formal presentations after that. But before I declare the annual general meeting open for business, I'd like to acknowledge the traditional owners of the land in which we meet today and their enduring connection with us wherever we might be. For us who are here in person, this is the lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past, present and emerging. So I'd now like to declare the AGM open for business. The company secretary, who's Kurt Lakovich, has advised me that the meeting is properly constituted with a quorum of representatives from members present. So that's a relief. The company secretary, that's Kurt Lakovich, has advised that apologies have been received from a number of individual members of CTA, and these will be listed in the minutes of the meeting. I also take the opportunity to welcome Fran Zanon, representing Deloitte, the auditors of the company. Fran is available to take questions from the members. I'm not sure where Fran is actually. Welcome, Fran. And in terms of receipts of proxies, so we've received 14 proxies, so just so people are aware of that. And now to open our proceedings, I'd like to welcome and introduce the Honourable Jed Kearney, MP. So Jed Kearney is the Assistant Minister for Health and Aged Care and is actually sitting in Parliament in Canberra at the moment. So she has instead provided a pre-record message to open our AGM. So Jed Kearney is currently the Federal Minister for Cooper. She's served in Parliament since March 2018 when she was elected in a by-election. She's the first woman to hold a seat. Jed started her working life as a nurse and rose to become the Federal Secretary of the Australian Nurses Federation from 2010. She then served as the President of the ACTU, the peak body of Australia's union movement, where she fought for better conditions for Australian workers. Jed's working life from nurse to President of the ACTU to parliamentarian has been about fighting for rights of others. So with that, I'd like to welcome Jed.
Well, good evening. My name is Jed Kearney, and as Assistant Minister for Health and Aged Care, I'm delighted to open the Cancer Trials Australia AGM, celebrating 30 years of excellence and 20 years as a non-profit member organisation. I am recording this message on Ngunnawal and Ngambri land, and while you meet on the Wurundjeri Woiwurrung lands, I pay my respects to all elders past and present, and also share how proud I am to be a part of the government committed to implementing the Uluru Statement from the Heart in full. I also acknowledge the vital work that Cancer Trials Australia does in ensuring cancer patients have access to clinical trials across Australia. Regardless of background or postcode, Cancer Trials Australia has worked hard to ensure everyone, regardless of where they live, have the opportunity to be part of a groundbreaking clinical trial. The founders of Cancer Trials Australia, many of whom are in the room tonight, are to be congratulated for their leadership and work in this important field of medical research. In fact, everyone involved in the organisation's journey over the past 30 years should be immensely proud. With a membership of almost 40 hospitals around Australia and New Zealand, I understand the Cancer Trials Australia team now supports more trials in this country than any other organisation. Last year alone, Cancer Trials Australia supported 232 trial approvals and prepared and submitted almost 1,500 trial amendments and members enrolled more than 1,100 cancer patients. Such clinical trials are critical to advance new drugs, medical devices and treatments and ensure the health system is self-improving and sustainable. Australians collectively owe a great deal of thanks to our medical and health researchers for advances in medical knowledge. We want Australia to be a preferred destination for clinical trials, and the industry itself represents a significant opportunity for the country in terms of participants, improvements to the health system, and the economy. We want to make it easier for patients, researchers, and sponsors to participate in and conduct trials and research. So to that end, we are strengthening and reforming the operating environment for clinical trials and research in ways that will inform and support your work for many years to come. And this includes nationally consistent accreditation of public health organisations through the National Clinical Trials Governance Framework, and developing an accreditation scheme for the cross-jurisdictional National Mutual Acceptance Scheme, and a one-stop shop for clinical trials and human research. This one-stop shop will also give us the opportunity to gain a better understanding of a cause close to my heart. It will allow us to better understand female representation in clinical trials and research. For many years, women have been more likely to be over or under-medicated with the dosages administered based on clinical trials that only included men. The data on gender-based recruitment to clinical trials is limited, and I look forward to gaining more insights when the one-stop shop is established. There are other important developments that I know you'll be watching. Cancer Australia is well underway on its work to finalise the Australian Cancer Plan, and we are committed to National Comprehensive Cancer Centre Network with new centres in Sydney, Perth, Adelaide and Brisbane to join the Melbourne Centre where you're meeting this evening. Cancer Trials Australia continues to ensure our country remains a destination of choice for international clinical trial sponsors, securing earlier access to novel therapies for Australian cancer patients. Cancer Trials Australia has my heartfelt gratitude, as do all of our wonderful health and medical researchers for their work and the good they do for all Australians. Thank you again for the invitation to open the AGM.
Okay, thank you very much to the Honourable Jed Carney there. So that was fantastic to see. And I think some positive messages there around some of the initiatives that do look like they'll be moving through, given the recent federal budget that we've had. So I think that's great to hear. Now, I'd like to move to the next part of the agenda. So adoption of the minutes of our previous AGM. So the minutes of the previous AGM were held on the 19th of May 2022, have previously been distributed to all members attending today. I move that the minutes of the previous AGM be received and adopted as true and correct. Would someone care to second this motion? Dish, thank you. And Mark, thank you. Any discussion or questions about the motion? Excellent. I now put the motion in play. All members in favour, please raise their hand. Good, you've got that. Excellent, thank you. All members against, please raise their hand. And the proxies that I carry did not raise their hand on that occasion. I declare the resolution carried. Thank you. So I'd now like to move on just to a brief report as the chairperson. So I'd like to actually start by congratulating the CTA team led by our CEO Kurt Lakovic and his leadership team for another very successful year in 2022. Needless to say, it was particularly challenging, but I think the team has got through incredibly well, and it's wonderful to see many of the team members here tonight. The key highlights, and I'll keep this at a very high level as Kurt will be following with more detail in his CEO report, but I wanted to highlight a couple of things which I think are really important. So again, the CTA team continues to provide very strong support for our member organisations, and I think that's something we're all very grateful for. There's been further growth in membership, including key centres from outside Victoria, and Kurt will again highlight these in his presentation. And I think the organisation continues in a strong and stable financial position, despite the challenges that the last 3 years has thrown at it. So that's been really pleasing to see as well. And at a board level, we've had a number of dedicated discussions on refining our longer term strategy. And we're really pleased with the core activities of CTA. So I just wanted to make that very clear to all those in the room. And we don't propose to fundamentally change these, but there are some areas in which we feel that the organisation can be enhanced even further. This is through engaging further and ensuring that the cancer clinical trial sector has a really strong voice advocating for it. So I think that's particularly important. And finally, I'd like to thank my fellow directors for their efforts in helping govern and guide CTA through another year. And in particular, I'd like to thank 2 of our board members who are retiring as board members. Mark Shackleton, who's in the room. Mark has served for 6 years as one of our Metro representatives. So thanks, Mark. And Craig Underhill, who couldn't join us tonight, but Craig has been our regional representative for the last 6 years. And both Mark and Craig have provided outstanding support to the board as well. So I'd like to thank them at this moment. And as of tomorrow, because this is Mark's last day actually officially on the board, as well as Craig, I'd like to welcome 2 new board members. So Sophia Francis. Sophia is a medical oncologist based at Monash, and she's a Metro representative. And Sam Harris from Bendigo Health. Sam is a medical oncologist and is our regional representative as well. So they joined our board meeting earlier today as observers, and we're looking forward to them joining us beyond this. Okay, I'd now like to hand over to Kurt, who will provide us with his report.
So I'm pleased to stand here in front of you. I think it's the 7th time that I've stood here and given a summary of the previous year. The first 5 with Andrew Scott as board chair, a period I'm still recovering from, and the last 2 with Jayesh as board chair. It's great to be able to stand up and highlight some of the successes of the previous year. 2022 saw more growth at CTA on the back of consistent growth off the 5 years before that. So we remain a not-for-profit member-based organisation, now consisting of 37 members, so 34 clinical sites and 3 medical research institutes across Australia and New Zealand. I'll come to a map on the next slide. 2022, we welcomed 2 new members. So first of all, Princess Alexandra Hospital in Queensland, the first Queensland member of CTA, the largest trial site in Queensland. And then secondly, building on growth into regional areas over the previous few years, Mildura-based public hospital, their trial unit opened only a few months ago. And to date in 2023, even though we're here talking about 2022, 3 new members have been welcomed already. So Scientia Clinical Research, Prince of Wales Hospital, and St Vincent's Hospital in Sydney. So all 3 in New South Wales. And we've got a few more potential members reviewing service agreements right now. So the CTA team's grown to 55 individuals. Many of them are in the room tonight. We've got some open positions as well, because there's more growth to support going forward. We're working within a hybrid model, so from home and the office here, as well as at some of the sites that we support with services. And we're supporting those activities both here in Victoria and in other states. So the current members are listed inside our annual report and also on this slide. What you will see is that over recent years, we've expanded into all major Australian states with the addition of Queensland last year. And it's the first time in CTA's history that we are now less than 50% Victorian, which I think is a big achievement over the last few years. Jayesh covered much of this previously. Off the back of only 1 change in each of the 3 previous years, there were no board changes in 2022. Tim Murphy was reappointed, which was great. And the current board comprises Jayesh as chair, Z1, and Mark Shackleton as the Metropolitan representatives, Craig Underhill as the regional, Claire Scott as the Research Institute member, and independents Michelle Gallagher, Colin and Tim. I think apart from Michelle and Craig, all are in the room tonight. And as Jayesh already covered, both Mark and Craig are retiring from the board this evening and washing their hands of CTA. And instead we have Sam and Sophia joining us. Looking forward to working with both of them going forward. In terms of our activity in 2022, just some highlights. Despite some lingering COVID challenges presented across 2022, startup submissions were pretty much on par with the previous year on the back of growth over the years before. Amendments were significantly up, so nearly a 30% increase in amendments in 2022 compared to the previous year. So the complexity of trials continues to increase, and it's never been more important that sponsors, CROs and sites work together to ensure we remain competitive, because it's important to ensure the international sponsors continue to send their trials to Australia. Most of the trials run here are undertaken by international sponsors. Open to accrual trials have steadily increased since 2016, and these jumped further to 544 as at the end of 2022. So that's about a 17% increase over the year. When reviewing this by trial phase, which is the graph on the bottom right, it's evident that the most significant growth has been in phase one. It remains about a threefold position over where it was 4 years ago. This graph again is at a point in time that number has bounced up to 168 again in terms of phase one trials open across the membership. I think this graph probably, from a clinician perspective, is probably one of the most significant aspects that CTA's had in this space. So if you audit the phase one trials that have opened in this country since 2012, more than half of them have been run through CTA members and less than half around the rest of the country. And that's evident here. So roughly 55%. So that's a significant achievement. It means the more complex trials are coming to CTA members. It means there's more experience then in being able to run those trials, including cellular therapies, personalised cancer vaccines, bispecific antibodies, and so on. Almost all of the major first-time in human capable centres across Australia are now members of CTA, with Princess Alexandra adding late in 2022. So Victoria continues to lead in this space, and there's a greater opportunity for Victoria to bring some of the other states along on the journey. In terms of the key outcomes from the management team's focus in 2022, the key programs were expansion of our membership, which we've covered, as well as service provision to our members. We completed the rollout of Clinibase, so transitioning from a licensed CTMS to one that we co-developed with software development firm Cardiobase here in Melbourne. So that transition finished in the first month of 2022. We continue to work on additional features for that product, so that'll be an ongoing process. An advanced reporting tool is about to be released to the sites that will allow them to filter and address questions that they have on the metrics that are captured in that platform. We've also now incorporated the potential to capture ATSI information, CULD information, because that will be critically important in driving the sector forward. Diversity is becoming more important, not just to government, but also to trial sponsors. The phase one fellow program entered its third year, so that supports fellows dedicated to phase one trials at 5 CTA member sites, 4 in a metropolitan setting and 1 at Bendigo Health. So really this is about growing phase one capability across the state, because phase one is where we add more value. The annual Victorian Cancer Clinical Trial Census will transition from Cancer Council Victoria to CTA this year. So building off the back of what CCV has been able to achieve since 1988, CTA will take carriage of expanding this, capturing a little bit more detail in the metrics and enabling that in a real-time fashion for the majority of our sites. Because less clinicians were travelling to the international meetings through COVID, an initiative from Ben Tran, phase one Tumor Group chair, was to develop some dinner updates where outcomes from the major meetings could be presented. And these were sponsored by our pharmaceutical and CRO colleagues, and were quite successful to the point that those sponsors have all agreed to fund those dinners this year. The first one is already earmarked for the 21st of July. I realise you can't click on the link on my slide, but if you drop me an email, if you haven't received an invitation, I'm happy to share the link with you. We welcomed 5 new babies, which was a record for CTA. And we really benefited from very low turnover. I mean, this is a sector that often has quite high turnover. The job of everyone in the team becomes much easier when you have only 4% turnover and you're not chasing your tail trying to find staff and train staff. So that's something we're really focused on continuing going forward. We can't avoid financial information at an AGM, unfortunately. So there's a single slide with 2 graphs. After investing significantly in our information systems capability in 2021, we returned to a surplus position in 2022, roughly $50,000, which is less than 1% of our operating budget. Our gross revenue and funds transferred to our member sites, which is the graph on the bottom right, have grown steadily since 2016. So now about $40 million was transferred to our member hospitals across the calendar year, and that's an increase of 19% on the previous year. Advocacy and engagement remains a critical focus, and as COVID restrictions eased, that became a little bit easier. So I've listed here the types of organisations that CTA engages with on a regular basis for different purposes. I won't read them out. It's really only by working with all of the stakeholders across the sector can we continue to ensure a strong ecosystem for clinical trials here. And the transition of the census program to CTA and the depth of data we will be able to capture with that process will put us into an even stronger position to be able to advocate based on the data as opposed to what we think is happening. The current strategic priorities are listed here. There are 5, and there are specific projects underpinning each for each calendar year. So for 2023, invest in our staff, and I've covered off on why that's important already. The quality of our service delivery to our member hospitals, investing in and leveraging the IT system and the data that we collect, growing our voice in the advocacy space, and then continue to support translation of Australian discoveries, which you'll hear a little bit more about later this evening. As always, I'm happy to take questions of our members or the general audience, if anybody has any. Andrew Roberts, gold star for you.
Oh dear. No, Kurt, thank you. That's very encouraging and exciting to look forward. I'm interested in the clinical trial census and just wondering how CTA is going to present that data. Is that going to be publicly available live or recorded once a year? Or how accessible is that going to be and what's your outlook? Almost certainly you have a contract, but we'll have a contract with the Department of Health. So I'm just wondering, what about us who aren't part of it?
Yes, so look, you've hit the nail right on the head. We'll produce an annual report in a very similar way to what CCV has done in the past, but the intention is also to allow a web accessible portal so that high-level de-identified information will be publicly accessible. We'll also be taking carriage of managing data requests in the way that CCV has done for a very long time. So instead of going to CCV to ask for specific data, you'll be able to do that through CTA.
Right.
Yeah. Dish.
Thanks, Kurt. A great presentation. So, I'm glad that the Minister's so positive about the National Clinical Trials Governance Framework. The sites might be slightly different. But, does CTA have any strategy or plans to help the sites with their accreditation requirements under the governance framework? I was very pleased to see you're collecting data on ATSI and called status, for example. That'll be particularly helpful.
So I think that's the intention. So the power in Clinibase is that we collect the information that will be required, not all of it, but the CTA relevant information will be collected in Clinibase, and we will will enable the sites to generate those reports. And not only that, I think the other piece that we've done is highlight what fields we capture against the fields that are required. So it will be blatantly obvious what the sites need to capture through other systems that don't touch CTA. I did want to touch on Jed's point. So Jed had a comment about female participation in clinical trials, which meant I was going to go and check what our participation was last year. So out of the 1,100 patients we recruited, 48% were female. And if you segment by phase 1, it was 51% female. So very much line ball, which is great. And probably has been the case for many years, I think. No more questions. Happy to take. Oh, one more question.
Hello, everyone. Yeah, 4% turnover, Kurt. Really good. Secret.
Well, Brenton, I'm glad you didn't ask a cybersecurity related question. I don't know that there's a secret. There's a whole bunch of elements that interplay there. It's the right environment, it's the right culture, it's involving staff in that process. To be honest, I think we can do more and we can do better. It's very difficult with a hybrid working environment. There's no secret. Sorry. Flexibility, remuneration. I mean, you can look at the surveys of what's important to staff, culture. You can ask the staff, actually, when we get out of the room. All right, looks like no more questions. Thank you. I'm outside if anybody wants to ask more questions after the AGM.
Excellent. Kurt, fantastic. And again, congratulations to you and all the team actually on what you've managed to achieve in the last year as well. So now we'll move back to the really exciting formal part of the AGM again, which is the adoption of the 2022 annual accounts. So it's the part that everyone's been waiting for. So the special purpose financial report for the financial year ending the 31st of December 2022 were approved by the CTA Board of Directors at their meeting held earlier today, and copies have been made available to all members. CTA has again achieved an excellent financial result with gross income up 18% to almost $6 million and the net result of a surplus of $51,837, which was significantly better than budget, especially given the ongoing investment in areas such as information management, as Kurt had talked about earlier. Deloitte, who are our auditors, reported an unqualified audit opinion. The financial report and the reports of the directors and the auditors are now laid before the meeting. Are there any questions or comments from members regarding the financial report or the reports of the directors and auditor? No questions? Okay. Are there any questions or comments on the management of the company? No questions. Okay. Are there any questions relevant to the conduct of the audit and the preparation and content of the auditor's report to be put to the auditor? No questions. Okay. So given that, I move that the special purpose financial report for the financial year ending the 31st December 2022 is received and adopted. Would someone care to second this motion? Thank you. Andrew Scott. Got in before Mark. Any discussion or questions about the report? Okay, it's a no. I now put the motion. All members in favour, please raise their hand. So, got that, Kurt? Thank you. All members against, please raise their hand. So that's a 0. I declare the resolution carried. Thank you very much. Now, moving on to other business. Is there any other business that can be lawfully brought forward? No? All right. Well, thank you, everyone. I thank everyone for their attendance, and that concludes the business of the annual general meeting. So I now declare the annual general meeting closed. Excellent. Thank you. Okay. Now for the fun part. We can now move to the informal part of the evening. So, look, it's really wonderful to be able to celebrate 30 years of CTA since it began as the CDCT, and we'll hear some personal stories around that, which was incorporated in 2003 as CTA. I'll keep this brief, but I guess as an introduction, because we'd really like to hear from some of those who've helped initiate, to develop and to grow the organisation into what we've become now. But, I'd like to start on a personal note, and we'd really like to highlight how significant a role CTA has played in supporting investigators, in supporting the member organisations, in bringing the most innovative trials to our patients. And as importantly, to foster a very, very strong culture of driving innovation through collaboration and being bold and confident in taking tasks to be able to achieve what is otherwise actually a very highly competitive global space around bringing such trials to a place like Australia. So I'm really sort of looking forward to understanding how this has evolved into becoming such a unique organisation, because CTA really is unique. Some of us think it's unique from a global perspective. It certainly is unique in this part of the world. And one that when I've talked about CTA elsewhere, it really is envied in how it could be possible to have such an organisation which is actually so collaborative in its nature, and to flourish and develop in the way it has. So, I think in saying that, I can't think of a better person to start our evening off with than George Morstan. So Dr. George Morstan was one of our founding board members of CTA, as well as a FASC member. George's biography is such that he's had more than 25 years of experience in the biotechnology industry, including as Senior Vice President of Development and Chief Medical Officer at Amgen. Dr. Morstan had overall responsibility globally for drug development in all therapeutic areas, including neurosciences at Amgen during that time, and was a member of the operating committee as well. Many new products were approved and launched during his tenure. Prior to joining Amgen, George was in fact the principal investigator on the earliest clinical studies of the hematopoietic colony stimulating factors, or GCSF, which were of course cloned here with that development work done at the WEHI and the Ludwig Institute. And the CSFs were subsequently approved and launched and were a major medical breakthrough that have been used to reduce side effects of chemotherapy and enable transplantation in more than 20 million patients worldwide. So really, truly significant breakthrough. And the CSFs have become multi-billion-dollar drugs, as we all know. And since returning to Australia, George has been a non-executive director of various not-for-profit and for-profit companies, including many biotechnology companies as well. In terms of George's background, he's a medical graduate of Monash University and obtained his PhD at the Walter and Lazarsville Institute and an FRSCP in medical oncology, following a fellowship at the National Cancer Institute in the USA. He's currently an advisor to companies including Symbio in Tokyo and Limos Biotech and TroBio. Is a member of the Australian Institute for Company Directors. Sorry, George, it's a long bio I was given. Has obviously continued to drive and actually support innovation within Australia as well, which has been wonderful. And I think you'll see in the annual report there's a photo of George Morstan and Dick Fox standing next to the first patient who received GCSF. And that photo has been around in a number of our organisations. It was at the WEHI, the Ludwig, at Royal Melbourne, and was very inspiring to myself as a fellow and as a young medical oncologist, knowing that that first patient was treated, in Melbourne, and what a significant effort that's been. So, George, please.
Thank you for that undeserved introduction. And just I'm going to have to take 5 minutes out of the 10 minutes you've allocated for my discussion. All right, so you need to now forget a lot of what you've heard. It's an amazing, incredible organization now, but I have to take you back to 1987, 1988, 35 years ago. So thank you for inviting me to talk about this period before Cancer Trials was formed. The publications that emanated obviously were, as you've heard, highly cited and influenced the development of hematopoietic growth factors. Many, or if not most, certainly of the older ones here, will have their own recollections of our origins, which were really, as you heard, in the biotech industry and the ability to make proteins that both Amgen and Schering-Plough were able to commercialize after work that was done here. So what I'd like to focus really on is a few anecdotes that I think reflected the value, reflective the values of Cancer Trials Australia as it subsequently evolved. But this is sort of, from my perspective, how it started. At the Royal Melbourne Hospital, we're in the fortunate position of adjacency to the Ludwig Institute, led by Tony Burgess, and the Metcalfe Group at the Walter Hall. We were harvesting the 20 years of work done to identify blood cell regulators. Tony was very determined that early studies of the hemolytic growth factor should occur where they were discovered, and the institutions were very supportive, and Ludwig had a clinical as well as a science mandate to do this. What happened then is now commonplace, as you've heard, but few, if any, first-in-man studies had been done in Australia, particularly in oncology, when we took on this task. I'd like to say that through good planning, but really through goodwill and the Australian can-do approach, we convinced both companies to work here, promising both a clinical understanding of these potential of these drugs, GCSF and GM-CSF, and an expansion of scientific knowledge, and that this knowledge would lead to new opportunities. We were pretty ambitious. We tackled issues pragmatically with a lot of support. There were large meetings involving the clinicians, including Professor Fox, Michael Green, Bill Sheridan, Graham Leschke, Linda Campbell, Dolmar, many others that are listed on the publications, and also sometimes Amgen staff, and I'll only focus really on the work we did with Amgen. I can't acknowledge everyone that was involved, but their names are on papers and on the acknowledgements. I'll speak about Amgen-supported GCSF studies as an example of how we defined the challenges and the need for CDCT and subsequently Cancer's Trials Australia. As you've heard, we performed one of the first 3 first-in-man studies in Melbourne. The beginning of this was inauspicious. Amgen initially hired a regulatory contractor in Australia called Michael Crawford, who, returning from Amgen in California, was involved in a tragic plane accident over Hawaii and perished. In 1986, I only knew one other person that had a potential contract research organization that we could hire to monitor our studies. And we'd introduced Amgen to Jenny Marty at the Institute of Drug Technology, who happened to be at the Pharmacy College at the time. And Amgen hired her for her regulatory and clinical monitoring. We didn't then need a TGA approval as well as ethics approval within the hospital. And Bob Fraser, head of the scientific reviews for the ethics committee at the Royal Melbourne, was again very supportive based on his experiences with the TGA. The first batch of GCSF that was supposed to be flown to Australia was left on the tarmac at Los Angeles Airport and fried in the LA sun. Then Michael Downing, who was head of Amgen Regulatory, personally brought the next vials of GCSF to Australia. He later worked for me at Amgen and told me he was greatly taken aback when I met him at Melbourne Airport and shouted, "Have you got the drugs?" in front of the Australian Federal Police car that happened to be parked nearby. And I'd left him with the impression that I expected him to hand over the vials and fly back to California. Our first value was enthusiasm, which we overdid. Mike thought we were likely to start our trial without TGA approval, and while the vials were stored in the pharmacy at Royal Melbourne Hospital, he gave Jenny Marty strict instructions to remove them at the first sign of trouble. This enthusiasm also taught me that we could not contact the TGA ourselves as investigators and encourage them to move faster. We're in a competitive race, and that regulatory agencies did not appreciate pressure even over an Australian discovery from Australian investigators. The next value, as you've heard, is communication. We convinced Amgen in Southern California we were no further away than UCLA. We would fax blood counts to Thousand Oaks daily in California. Then Bill Sheridan bought an Apple II, and we could create line graphs, but we obviously could not email them. So again, they went by fax to California. The next value we sort of identified was patients at the center of all we do. We learned patients were enthusiastic to join phase 1 studies, this was the first, to help others, and welcomed the added attention and involvement, particularly from our research nurses. Patient numbers were a problem from the beginning, but in the 1980s, patients had fewer options for therapies, and we were able to include a good number of patients with various malignancies in our phase 1 studies. We could not, however, do what our competitors overseas were doing, which is a study in one tumor type, like lung cancer or bladder cancer. We just didn't have the depth of patients in our institution. Our focus was on patients, not income. It was an early time. We did need funding for pathology costs, but not other costs or investigator time. There were no ethics committee fees that I remember. IDT sold us as first-class science at third world prices. And in fact, the US dollar bought 2 Australian dollars at that time, and we were naive as to what US centres were charging for phase 1 studies. We felt we owed it to patients to work as closely as we could with industry, and all our advice was seen to be part of the collaboration. The next value is intense scientific study. Even though we had to enroll patients with various different malignancies in the same trial, we did intensive investigation in collaboration with laboratories at WEHI and Ludwig. And the pharmacokinetics and the role of neutrophils in eliminating GCSF was identified by Judy Layton, which led to long-acting Neulasta, a product of Amgen. It's been well documented that Uli Dursun identified that GCSF led to increasing in circulating progenitor cells, and this led to an improved peripheral blood progenitor cell transplantation led by Bill Sheridan and based on work done by Chris Yatno in Adelaide. Another value was collaboration and respect of each other. It was clear that one centre could not undertake the clinical program alone, and the early studies needed to involve more centres. The bone marrow transplants trial involved St Vincent's Hospital in Sydney. The peripheral blood progenitor cell trial involved Chris Yatno in Adelaide. And when we came to the treatment of febrile neutropenia that Daryl Maher led, we needed even more centres in Sydney, Queensland, and Melbourne. Ethics committee review as we grew. Ethics committee review became complex as we grew. Each hospital had its own ethics committee and insisted on its own reviews. Professor Fox was leading efforts for mutual recognition, even at that time. Jenny Marty and IDT monitored the studies in all of the centres. We hired research nurses and were able to get wonderful nurses for many reasons, including they did not have to wear uniforms and were able to manage their own time. I wonder if that has something to do with staff now. It was clear that the clinicians, the nurses, the scientists and management in the hospital was very supportive of these early studies. We were learning together. Another aspect of collaboration was investigator meetings. This was a time when biotech and pharma companies could fund meetings without any recognized ethical dilemmas. Amgen paid for an investigator meeting at Port Douglas, where many of the leading oncologists attended to discuss the studies and future direction of the work. This was before any commercialization of GCSF. My memory is there was a lunch and a snorkeling boat trip where the water became rough on the way back, and many of the leading oncologists in Australia at the time became green with illness. Another value was quality. We assumed that the protocols would be followed as written, and all patients would be eligible and all data would be collected accurately as the protocols demanded. We achieved greater than 95% completion, except for one investigator who I'll not indict 35 years later. However, when I joined Amgen, I realized how good our data quality was compared to the more expensively conducted clinical studies in the US and European centers. And we continued placing studies of new molecules like thrombopoietin and stem cell factor in Australia. Another value I'll mention is saying what you do and doing what you said. We learned patients were the most important, but meeting industry needs was also important. In industry, the Gantt chart and timeline were the drivers of the project, and making and meeting commitments was key. We provided all advice free. We wrote an expert report for the approval of GCSF in the WEHI library with 4 people from Amgen over Christmas between 24th of December and 1st of January 1990. The science-based approach to clinical research paid off in many ways. We met our promises to Amgen, including new indications like peripheral blood cell transplantation, the bulk of the pharmacokinetics required for drug approval, and the development of a long-acting GCSF. We also provided significant insight on GM-CSF to Schering-Plough, and these also involved a rich scientific program, which I won't discuss, but Graham Leschke, Jonathan Seaman played important roles. Another consequence of these studies was a number of those working on those projects, including, to my knowledge, Daryl Maher, Russell Basser, Bill Sheridan, Jenny Marty, Errol Malta, moved to biotech and pharma industry. The centres continued from strength to strength, and I think, as we've already heard, how CDCT and Cancer Trials Australia, while holding on to many of the values that we sort of stumbled across or identified early on, scaled up and created a fantastic science-based drug development organisation. Thank you.
George, that's just fantastic, and great, very personal insight into things, as well as a good demonstration of that really can-do Australian attitude, which must have been fun when you moved to Amgen to not have that. I'd now like to welcome our next speaker, who's Professor Mark Rosenthal, So Mark, of course, would also be very well known to everyone in the room. Mark's a Senior Staff Specialist at the Department of Medical Oncology at the Peter MacCallum Cancer Centre, Director of the PCCTU and Clinical Trials Lead for the VCCC. His major interests include neuro-oncology and early phase trials. Mark trained as a medical oncologist in Melbourne and Sydney in Australia. He was awarded a Doctorate of Philosophy for a thesis examining the molecular genetics of colon cancer. Now, what happened from there, Mark? Conducted at the Ludwig Institute for Cancer Research, and that was from 1992 to 1996. Mark then completed postgraduate training at New York University Medical Center from 1996 to 1998. And was a senior staff specialist at the Department of Medical Oncology at Royal Melbourne from 1998 to 2016, as well as being the Professor Director of the department from 2006 to 2016. Mark, of course, is here because he was Chairman and Chief Medical Officer of Cancer Trials Australia from 2006 to 2016, and was the inaugural Chairman of the Cooperative Trials Group for Neuro-Oncology, which he chaired from 2007 to 17. So we look forward to Mark's wise words.
Wow, what an organisation, and so different to what it was. I might just start by saying that George taught me a very important lesson about serious adverse events. And I reckon it might have been the second patient ever to receive GM-CSF. I'm not sure, he was an old dentist, and he was on 3 West, and we found him cold at about 6 in the morning. I didn't think too much of it. He was on the trial. I'll give George a call at some stage. And about 8 o'clock, I thought, probably time to ring George and let him know that the patient had died after 1 dose. And I rang, and before I put the phone down, George was bolting down the ward, closed, and I reckon within 5 minutes was on the phone to the FDA. And I learned an important lesson that if a patient dies on a clinical trial, that's a serious adverse event. The CDCT, the startup of that organisation, it was a unique and inspired moment of collaboration between clinicians, researchers, and I might add skilled administrators. I started working, I thought it was 2001, but maybe I can't remember properly, but I really followed in the deep footsteps of Darryl Maher originally, and then Russell Basser. And we realised around 2003 or so, and a bit later, that we had to become more sophisticated. Tony Burgess, who's here, where did I see him? Up the back somewhere. Tony, who'd been involved with the Centre for Developmental Cancer Therapeutics, the CDCT, he was really cross at this time. He couldn't believe someone could come up with such a ridiculous, cumbersome name. And I actually had to sheepishly point out that it was him who came up with that original name. So what did we do? We had a competition to come up with the new name. I think it was a $100 David Jones gift voucher. And famously, Andrew Roberts submitted over 30 names, including the ambitious and not entirely accurate Cancer Trials Australia. But it's changed. It really is Cancer Trials Australia nowadays. So we established the not-for-profit company, limited by guarantee, Cancer Trials Australia. Now, I've asked Kurt once, Josh, what's the logo mean? Right, so Tony, I can't remember, no one knows. The logo is actually 6 rings. Well, that 6 rings representing the 6 members. So Western, Royal Melbourne, Peter Mac, Austin, and the 2 research institutes, Ludwig and WEHI. So that for everyone in the audience who has never thought about that logo, that's what it means. And Colin, you and I are probably the only people who remember Spirograph as a toy. We need some very clever Spirograph work to encompass all the other members. So we started off with a board with a representative from each of the members, chaired by Michael Green, a CEO, me. And for me, Cancer Trials Australia achieved at least 4 quite remarkable things in my time and the time of others. So first, building on the CDCT, Cancer Trials Australia established a collective of cancer specialists from across Melbourne with a common purpose: how to bring novel therapies to our community. And perhaps for the first time, the collective established an overarching approach, an overarching strategy, and a strength with great depth and breadth of experience and expertise. Importantly, though, there was flexibility and respect for individual sites to focus on their strengths and pursue their own interests. I cannot believe it, but 20 years ago, I thought, Jonathan Seaborn, you are an idiot. Fancy doing immunotherapy in melanoma. Where on earth is that going to go? And of course, we now know that immunotherapy plays a critical role, not just in melanoma and other illnesses. Secondly, CTA auspiced regular scientific meetings with biotech and pharma, as we've heard from George, and it defined an approach that resonates today. And I think George alluded to this as well. Get involved early in the drug development program. Be free, and I mean free as in not costing anyone any money. Be free with our advice and give it without fear or favour. Be honest as to what we say. These were quite extraordinary times and great opportunities for early career researchers like myself, sitting at the feet of experts, learning how to review preclinical data, listening to discussions about drug development, and hearing some incredible ideas, expansive ideas on endpoints in clinical trials. PET scanning was pretty much brand new, and we had some wonderful clinical trials where PET became the endpoint. Quite an unusual endpoint at the time. Just as important for me and all the other young clinicians was watching how senior clinicians interacted with other clinicians and, just as importantly, scientists as well. How they conducted respectful but fearless meetings with biotech and pharma. And finally, how decisions were made as to whether to go ahead with a clinical trial or say, no thanks. The key question I learned 25 years ago, and it still applies in every meeting that I go to, is what's the mechanism of action? How does a drug work? And we still go to meetings where you ask that question and the biotech says, oh, I'm not really sure, it might, and you go, no thanks. It was the key question 25, 30 years ago, and it's still the key question. I added my own key question or requirement when reviewing the preclinical data, and I'm a little coarse sometimes. I called it the dog's balls phenomenon. If the preclinical data doesn't stand out like dog's balls, we're not interested. But that certainly guided me. The third thing that CTA did, in my mind at the time, was to establish an operational model that took all the drudgery out of site management, what I call site management. It took it out of the hands of the investigators, the research nurses, the study coordinators, and no longer did the trial unit team have to deal with the complex and time-consuming work associated with contracts and budgets and submissions and amendments, invoicing and debt collection. Although Michelle's here, I was pretty good at debt collection, I think. If they weren't paying, they got a very rude letter from the CEO, me, or the board chair, me, and I would say, if you don't pay up in 30 days, no, actually it was more like by the end of business Friday, close of business Friday, we will never work with you again. And even Amgen got scared. What it meant, though, is that the clinical teams could get on with their real job, which was trial conduct. And so CTA has built an enviable body of experience and expertise in site management. And it started with 4 clinical sites, and we've now got 35 clinical sites. Is that right? 34 clinical sites. So over time, the clinical sites around Australia and New Zealand, for that matter, have recognised the ability of CTA to take all that work away from the clinical trials units themselves and do the work with great expertise, efficiency and experience. Finally, Cancer Trials Australia took up a role in advocacy, and I was delighted to see Kurt put up that list of advocacy elements to what they're doing even in 2022. CTA has improved the clinical trial landscape through investment of surplus funds. Indeed, John Zaltzberg, who I don't think is here, he had a phrase: you can't cure cancer with money in the bank. It's a great concept, a great piece of knowledge. It's obvious. Use the money. And CTA has done a wonderful job over the last 30 years in using surplus funds to try and change the clinical trial landscape for the better and for our patients. And for a not-for-profit organisation, Cancer Trials Australia did some remarkable things through strategic investment. Some of Cancer Trials Australia early and prescient achievements included mutual acceptance, the Cancer Trials Australia Lab, great idea a little before its time, infrastructure support for regional centres, clinical trial networks, the first time in human CTN program, pre-screening consents, preferred provider status, the clinical trials app, the clinical trial management systems that CTA has brought to our sites, and the advocacy that I've mentioned. I've made it pretty clear that CTA has played a critical role in the support, the mentoring, the education, and the de facto training of so many people. Junior consultants like me, other research and trial staff. CTA established the associate directors who attended board meetings, and I think, Joe, you were one of the very first. The heads of tumour groups, meetings of the managers of the clinical trial units, and meetings, annual meetings of the research nurses from around Victoria. There was a group of young trainees back in the day, myself, Graham Leschke, Andrew, Russell, and many others who were inspired by people like George and inspired by Tony Burgess. We were inspired on what was going on around us, and we were taught and mentored by the very best. And the mentoring and education continues to this day. CTA enshrined and embraced the policy of renewal and reinvigoration, whether that be the board chair, board members, heads of tumour streams, or I love looking at the back of this book, current member directory. I don't recognise 17 of the names here out of 37. That's an extraordinary observation, really, when you think about the reinvigoration of Cancer Trials Australia. Young stars, young guns taking on roles and responsibilities within the framework of cancer clinical trials. Personally, I am so grateful for the opportunity that taught me so much. From Tony's sense of greater good, really probably the genesis of Cancer Trials Australia, Michael Green's skills as a chair, Dick Fox's intelligence and perspicacity, Jonathan Seabond, God love him, his advocacy, George's quiet brilliance, and John's iconoclastic and incisive commentary. And then to my special friend, sadly, the late Steve Anderson, who some of you will remember. He was the Royal Melbourne member on the board, and he was actually the Chief Financial Officer of the Royal Melbourne. He was a wonderful man, unfortunately died of cancer. But what he did, he taught me so much about finance. But more importantly, he ensured that the fundamental focus of Cancer Trials Australia was always about the patient. How lucky I am to have worked with such exceptional individuals. I was also blessed to work with wonderfully capable administrators, Carol, Marcus, and then Kurt, as well as committed volunteer board members, all of whom had the ability to gently tell me what needed to be done and gently tell me how to do it. Cancer Trials Australia has had a profound impact on Australian cancer trials. It started with a very simple notion. The clinicians and scientists must collaborate to advance cancer medicine. From simple beginnings, CTA has fashioned how we do clinical trials in Australia, and in so many ways has led the way. And of what am I most proud? That CTA has played a significant role to ensure that patients with cancer have access to an array of clinical trials. That the non-English speaking 70-year-old from Hoppers Crossing has the same opportunity to enrol in a first-time in human trial as the wealthiest American living next door to a famous cancer centre. And that, my friends and colleagues, is an extraordinary achievement of which everyone in this room has contributed to in one way or another. Thank you.
Thanks, Mark. Very eloquently said. That's probably the longest speech I've ever heard you say. So you must have been very excited. No, it's fantastic. Look, delighted now to welcome Professor Andrew Scott. So Andrew, of course, was our most recent chair prior to myself. Andrew has made some really significant contributions to science and to medicine through the discovery of novel therapeutic antibodies that are impacting on cancer patient outcomes. And he's also had an enormous role in the development of evidence for the use of functional imaging, in particular with the use of PET, that has led to the approval of multiple Medicare clinical indications for accurately staging cancer patients and understanding biologically and functionally what's going on. He's provided leadership of scientific and medical professional organisations and in public education. Professor Scott is recognised internationally for his research and clinical expertise and for advocacy of molecular imaging and of therapy. And this has been reflected by his recent election as president of the World Federation of Nuclear Medicine and Biology. Andrew, of course, is a long-standing director of CTA and was chair of the board for 5 years until 2021. So really looking forward to what you have to say, Andrew.
Thank you very much, Jayesh. Well, it's a bit hard to follow George and Mark, particularly when they wouldn't tell me what they were going to be saying. So I'm actually going to give just a very relatively short series of comments in comparison to my prior speakers. A couple of things that Mark said and also George did resonate with me as well, because I think for many of us who've been in Melbourne for some time, and I originally came from Sydney, so I can make some disparaging comments now and then, was that the culture that's always existed in Melbourne and was very evident elsewhere in the country, even back in the 90s, for the collaboration between science and clinical medicine was always evident. You know, the biggest research institutes were in Melbourne. You know, the really cool trials were starting to happen here as well. And so when I was, again, a young lad, had finished my initial training in internal medicine, nuclear medicine, and thought antibodies and tumor immunology was pretty cool, and decided to go to the US and spent 3 years at Memorial Sloan Kettering working with Lloyd Old, probably the father of modern tumor immunology, and learning all about antibodies, how to make them, how to put them into patients, and really spent 3 years doing phase 1 trials and what that actually meant. And then given the opportunity to come back to Australia, but to Melbourne, and join Tony with the wonderful Ludwig Institute branch that he had, I thought this was fantastic. What I didn't realise when I was coming back was what the networking within the clinical oncology community was. And that was when I met a number of the people here today, particularly Jonathan, Daryl Marr, Russell, made a big impression, Andrew, Mark, and many others. And at that time, CDCT was just starting. And I'd spent 3 years doing phase 1 trials, but they really weren't being done very much in Australia at all. And I saw the way it was actually being generated, and I was very enthusiastic about that. And of course, through the Ludwig program, we started a lot of phase 1 trials at that time as well. So when I was asked to just make a few comments as to how I see what CTA has been and where it's going, and particularly in the context of innovation, what strikes me is that within Melbourne and within the CDCT and CTA, this intersection between innovation and clinical trials has always been incredibly strong. You've heard from George about how the colony stimulating factors that were discovered in Melbourne were put into patients for the first time in Melbourne. And this continued through the leadership of Darryl and Russell, and then Mark, in his inimitable style, creating an incredibly productive entity, which was CTA in about 2003, I think that it was. And when I think about that linkage of innovation, if you recall back to the beginning of CTA, 2 of the 6 founding members were actually medical research institutes. And part of the impetus that Tony inspired was to find ways in which we could take discoveries into the clinic. And there have been some successes from local discoveries, including venetoclax, and many others that are now going more into the phase 1, phase 2 setting. But as Mark alluded, there were also some major areas in which CTA really broke new ground. About 20 years ago, from a major grant that was obtained from the Victorian government, the wonderful CTA lab was first established as a way of trying to improve the way in which clinical trial biomarkers and PK and so on could be done. And I also sort of waved my hand, and we managed to get a little bit of money for PET facilities at both Peter MacCallum and at the Austin, which was really at a pivotal stage when the evidence for PET was actually being first developed, and the first of many Medicare applications that I've been involved with, which have now resulted in approvals, were actually being done. And that ability to say that we can do laboratory work, we can do advanced imaging, I think made a big difference to a lot of the big biotechs and pharmas when they decided to come to Australia and look at what was possible. And I think this strong engagement of local and international biotech companies in pharma continue. But I did actually go back to look at when CTA first started, and I found the very first brochure from 2003. And there was, in fact, a listing, it's a bit hard to see from the back here, of all of the key players that were present in the 6 major organisations that were involved with the establishment of CTA. And they had some, you know, not insignificant people like Don Metcalf and Suzanne Corey and Tony Burgess, and most of the people that you've been hearing about at Royal Melbourne, at Peter Mac, at the Austin and Western, were also pivotally involved at that time. And it was a very glossy brochure, but it really was a way of expressing what CTA's aspirations really were. And one of the things which really impacts, I think, on the way in which we can judge the success of CTA has been the way in which it has been involved with that innovation and translation and the phase 1 program. And I think the current board chair, Jayesh, as well as many of his colleagues, have played a pivotal role in the success of the way in which the phase 1 program is so successful in this country and really is talked about around the world. And you can see just the number of patients recruited per year has really dramatically changed, of course, in relation to the number of trial sites, but also because of the reputation that we have for doing these studies particularly well. One of the things that you have to do as a board chair is obviously be responsible not just for the conduct of the board meetings, but probably one of the most important things you do apart from strategy and governance is to ensure that you've got someone who can lead the organisation, the CEO that can actually perform those functions in an appropriate way. So I had 2 surprises in 2016. The first was when I found out that Mark was going to be stepping down as chair. And by the way, you're going to be the next chair. And I said, really? Okay, we'll have to talk about that. And the second was that Marcus Clarke, who was the CEO, retired. And so we then had to go through a process of recruiting a new CEO. And so we went through that process, and it really struck me that there was one individual. He was young, he was relatively inexperienced, but he really impressed with the way he embodied the values and the aspirations of CTA. And I think that Kurt has really taken CTA from strength to strength. And I asked him for one of the earlier photos of when he first came on board. He said, well, this is the earliest one I've got. It was from 2019. There's probably twice as many CTA staff members since that time. But an organisation can only work based on the quality of the people that work in it and the culture that they have. And I think that's, to me, been one of the highlights of CTA, the way that it has grown, but it also has grown in a very, very productive way with people that are engaged within the organisation as well as at the member institutions as well. So I guess in just final reflection, you've heard talk about the way in which the number of sites have expanded, the improvement in access to trials for patients. And I think particularly at the rural and regional level, along with the way in which we're trying to improve treatment for patients wherever they may be, that's been a particular highlight over the last, say, 5 to 8 years in particular. And I think that the advocacy that you've been hearing and the impact that CTA now has, and you saw the slide that was shown by Kurt as to all the organisations, governmental, non-governmental organisations, where CTA has a voice, is incredibly important nationally and internationally. And I'm sure CTA will go on from strength to strength in that regard. So thank you.
Andrew, thanks so much. Again, wonderful words and, you know, a great opportunity to reflect back at, you know, what's been, well, 30 years now of CTA from the time it was founded and the stories that George had really opened with. Well, we're going to have Michelle Gallagher speak as well tonight. Michelle is one of our board members and actually one of our independent directors. Unfortunately, Michelle has been held up in Adelaide and is unable to speak tonight. But I'm sure she will share perhaps reflections at our next AGM around that. So with that, I'd like to call the evening to a close. We have canapes and drinks out in the lobby and we can really enjoy that. And perhaps I might just sort of finish with one of the terms that Mark has used, and Mark has, you know, been a really strong mentor of mine for just a couple of years, which is that a lot of what we do is personal, right? We use that in the context of what we do in the context of treating patients with cancer, in the context of working in the clinical trial space, in the way that we interact as a community here. It's a very, very strong part of not just what we do, but actually the reason why we do it as well. And it makes it fun and it makes it meaningful as well. So go out, enjoy catching up with each other, enjoy, you know, a drink and a snack. And the opportunity to, you know, again, reflect on 30 years of CTA. So thanks again.